Hi, Dr. Lin.
Hello, hi, how are you?
Doing well. Thank you so much for joining us today.
Oh, thanks for having me. I feel underdressed. You guys are so dressed up. It's Saturday.
Wonderful. So we're just gonna wait probably one more minute as people hop on, and then our team is gonna start off with a very brief intro, and then we'll go into the Q&A fireside chat session. But just wanted to say thank you so much for taking the time on the Saturday to be with us, and we're so excited to get to learn from you and hear from you.
Fantastic. Thanks for inviting me.
And I did want to ask before we start, are you okay if we record this meeting?
Yes, no problem.
Okay, thank you.
Okay, well, I can go ahead and get started. I'm just going to share my screen here. So good morning, everyone, and welcome to Alcie's Distinguished Lecture with Dr. Bryant Lin. We are so pleased you all could join us this morning for this wonderful event. My name is Donna Tong, and I'll be one of the moderators for today's event. And of course, thank you so much, Dr. Lin, for taking the time to speak with us today. We are so incredibly excited and grateful for the opportunity to learn from you. For everyone here, we'll just give a quick introduction to the American Lung Cancer Screening Initiative, or ALSI for short, tell you a little bit about Dr. Lin, and then we'll dive straight into a fireside chat where you all can ask questions. So, ALSI is a national 501(c)(3) nonprofit that consists of over 500 students and physicians across the world. Our goal is to increase awareness around lung cancer screening and help connect individuals to lung cancer screening centers near them. We organize community outreach events on college campuses, health fairs, churches, community centers, and more. We also work with mayors, governors, and state representatives to increase awareness locally through political avenues. Through our outreach, we have spoken to over 35,000 individuals about screening, and we hope to keep pushing that number higher. And now I'll pass it off to my colleague, Jessica Balvin.
Thank you, Donna, for the wonderful update about what we at ALSI have been working on. Now, I would like to warmly introduce our distinguished speaker today, Dr. Bryant Lin. Dr. Lin is a primary care physician and professor of medicine at Stanford University. He's also the co-founder of Stanford's Center for Asian Health Research and Education, or CARE for short. He's also served as a training director for the Decide Center, which has created a novel shared decision-making tool for atrial fibrillation anticoagulation and is an investigator in several active clinical trials. Dr. Lin's work spans many aims, including but not limited to developing and testing novel medical technologies, improving the health of Asian populations, and increasing expression in the health field with humanities. Dr. Lin has an active interest in storytelling and filmmaking. He co-directs an undergraduate seminar called Med 53Q, Storytelling in Medicine, and has worked with a group of students on a documentary on end-of-life care at a Japanese American senior home in the Bay Area. He also co-teaches Med 216, Generative AI in Medicine. Dr. Lin was also diagnosed with lung cancer in May of this past year. He has been sharing his journey with lung cancer through a fall course at Stanford entitled From Diagnosis to Dialogue: A Doctor's Real-Time Battle with Cancer. We haven't even covered it all, but needless to say that Dr. Lin has a wealth of experience in several groundbreaking pursuits. It is our esteemed honor to have the opportunity to learn from Dr. Lin today. This talk will be a Q&A session. As such, we encourage you all to ask questions. If you would like to ask a question, please use the raise your hand feature. While we prefer that you ask questions verbally, if you feel more comfortable doing so, you can send them in the chat. Dr. Lin, it is truly an honor to have you join us today. Our audience today consists of undergraduate, graduate, and medical students, as well as physician mentors across our university chapters. So to start, can you, Dr. Lin, share a little bit about your journey with lung cancer?
Yes, I kind of use the word ironic because the center I started with my colleague Dr. Latha Palaniappan over 6 years ago. One of our first and continues to be a priority area is helping support research and education in lung cancer in never smokers, in particular the Asian population. And of course, I become a poster child for this disease, being Asian and never smoker and getting this lung type of lung cancer, which is called EGFR mutated lung cancer, where my tumors have this mutation, which Asians tend to get more than other populations. So yeah, of course, it was a shock, surprise. But the way I approach things is that if there are if kind of life, the life gives you lemons, make lemonade. So trying to get hopefully raise awareness for lung cancer research and screening and education, and hopefully that will have some impact. So my misfortune can be to other people's benefit.
Wonderful. Thank you so much, Dr. Lin. And I'll go ahead with our next question. So one of the things I was wondering is it's just to provide a little bit of context. So our audience here are mostly students and some doctors and involved in lung cancer research. And I was curious how your diagnosis has changed your perspective about, you know, lung cancer research and a lot of it's very interesting that you are already doing work prior to your diagnosis and just kind of the impact of your diagnosis on your perception of work and if that's how that's changed anything.
Yeah, I think so. So I think it has been reflected in. I always use this statement. As a doctor, you know, but you don't really know what a patient goes through. So it's been very much. Again, I theoretically knew, and I know, through my patients' experiences, what they go through. Being diagnosed and treated for cancer. But you don't really know until you live it, until you walk in those shoes. So I designed the class that I just finished this week on lung cancer around that idea, where um, we really emphasized the patient side. So rather than, typical class, especially at Stanford, where you're focusing so much on the science and the clinical studies, we really had a better balance to reflect the patient experience. So we had sessions on caregiving, nutrition, spiritual care, mental health, access. So, over half of the class was focused on those issues, which patients grapple with, day in and day out, as opposed to, you spend your day as a patient, really, 1%, I'm just making up a number, of your time in the clinic, getting, chemotherapy, getting, dealing with your treatment and diagnosis. Whereas, you spend 99% of your time living your life, right? Worrying about what you want to eat, who's taking care of you, who are giving, ride, who's going to give you a ride, who's, what are the kids going to do, right? When you're at chemo. So, that part of living is very important and is what we do. The other side, I just wanted to point out, we added this session on spiritual care in particular. And definitely receiving a diagnosis of cancer makes you think about those spiritual issues, maybe not in a strictly religious sense. And I'm not a religious person. I think you would call me agnostic at best. But it's very interesting how that has impacted me so much about how many people will offer to pray with me, pray for me. They will chant with me. They will send me prayers. They'll do all sorts of things from their religious backgrounds, their spiritual beliefs, and they've all been very touching and deeply important to me. So what I did was, as a good physician, I was, of course, opened up PubMed. I said, okay, well, I wonder how many entries are there for chemotherapy? 400,000 articles on chemotherapy in PubMed. So I typed in spiritual. How many articles about just spiritual, not even spiritual care? How many articles with spiritual as a keyword? 8,000. So, to me as a patient, chemotherapy is as important as spiritual care for my soul at this point in my life. So I just find it very fascinating how that emphasis and, perhaps it's because of the secularization, again, speaking as a not a religious person at all, how medicine has become more and more secularized over the years. And, chaplaincy, for example, chaplaincy services are not covered by insurance. There are codes for them under hospice care, but pretty much and large, they rely on volunteers and, hospitals supporting this. So, this journey has really been eye-opening in many ways to me. because kind of, again, as I say, I knew, but now I really know.
Thank you so much. Um, and then we put in the chat, if you have a question, feel free to raise your hand like Dr. Wood has done. And I see Dr. Wood, he's the chair of surgery at University of Washington, has joined us today and want to turn it over to you for your question, Dr. Wood.
Thanks. Thanks for letting me ask a question. Dr. Lynn, I'm up the road from you at the University of Washington, and I'm a lung cancer surgeon. I am wearing my Stanford sweatshirt in your honor. Um, um, and as a physician surgeon caring for people with lung cancer, I guess my question to you, you're on the other side of that. I'm sorry for that. But do you have insights for me that would say what are things that you see that we're often missing and how we intersect and interact with our patients with cancer that you would now give as advice so that we can do that in a more um, effective, sensitive, and appropriate way.
Yeah. It's a fantastic question. It's something I've thought about many times, and I've gotten kind of related questions about, how's been being a cancer patient changed how I practice medicine. So it's somewhat related to your question. And maybe, two things come up to mind right away. One is, it's always challenging to balance kind of the hope and prognosis, because people always ask, right, as a doctor, right, people always ask, well, what's my prognosis, doc? And it's interesting, I taught one thing that's been very helpful for me early on, especially, was talking to many other patients with cancer and listening to them, and especially doctors, because I'm like, well, kind of you're in kind of the group of people, where I'm coming from. So, um, one advice I got was great, was like, well, everybody needs and wants hope, but, of course, it's hard to have that balance between giving hope and being, you know, grounded in reality. So, I've been struggling with that because, in my mind, I know, based on older statistics, because, a lot of these are evolving, especially with EGFR and osimertinib, and, I'm under this newer, protocol from the Flower-2 study, where we don't, really know the prognosis that well. But, historic data is stage 4, 10% survival rate at 5 years, pretty, depressing, right? But a great piece of advice I got early on from a pulmonologist who has lung cancer. He said, you know, you got to not look at these survival curves. You got to not look at these things. But, you also as a doctor want to balance that with reality. So that's an interesting thing, because I find myself as a clinician being trying to be a bit more aggressive and hopeful in those with those cases, but again, without having a messaging that may be giving false hope or false reassurance. So that's been a struggle, but an interesting challenge, where I'm on that view of, we got to give people hope. We got to give people something that is, helpful at this stage. And of course, it depends on what stage the patient's at. The other part, I would say, in terms of working with patients, is, we have such limited time. I get 15 minutes. I get 30 minutes, but when I see the oncologist, really they get 15, 20 minutes. Everybody, especially some specialists, you're seeing so many patients, is really spending the time. And I've noticed, again, no offense to my own MD colleagues, we tend to focus a lot on the MD stuff, right? What's the chemotherapy? What's this and that? And the mid-level providers, I found, do a really great job of finding about, helping you manage your symptoms and helping you manage your side effects. So I think as MDs, I feel like, we can all take a page from their book and, look at them and, making sure we have more of a balance of what we discuss in that, unfortunately, very limited time. And lastly, it's really about zooming back once in a while. And I had a great talk with a colleague of mine. He was editing a book about history taking. And he said, well, one thing you should ask, one of the chapters is they emphasize you should ask about what somebody's hopes are for the visit. But to me, I'm like, well, I want my doctor to ask me about what my hopes are for my life, you know. And some doctors ask that, but I think we don't ask that enough, Even as a primary care doctor, that is such useful information to know holistically about your patient. What are their hopes, not just for the visit, but for their life. And obviously, with cancer care, that's, more directly relevant. But so those are my thoughts. Sorry if that was a long, long answer.
No, thank you so much, Dr. Lin. That was absolutely amazing. Always great to hear. And then I think Deepti has our next question.
I'll try to keep my answers shorter.
No, we love this. Thank you so much for being here with us, Dr. Lin. And my question is kind of more general. I just kind of wanted to learn what the process was like for you when you were getting diagnosed and kind of what the mental process was like as well. Like what was happening in clinic and then how were you processing that both as a doctor and as a patient? Thank you.
Yeah, so I guess first thing I probably did what doctors do but shouldn't do, which is I didn't take any time off, which is not good. Don't do that. Especially my generation and older doctors, we were in that generation where it's like, God, you'd never take time off. You're sick, and all these horrible stories, which about like, in residency, you're walking around with an IV because you're dehydrated and things that shouldn't happen nowadays. So that's one thing. Second thing is, I went through the stages of grief many times, and it's true, people go through the stages of grief in many different orders. So that happened very quickly for me. I was able to kind of um, come to a more uh, balanced realization and acceptance of my diagnosis. On the other side of, and this is again, you'll get me on my soapbox. I I am extremely privileged, right? I speak English, I have insurance, I have resources, I have family, I have connections, good health literacy, right? I check off all the boxes. So I was able to get diagnosed within 1 week, which is unheard of, right? It's just amazing. To me, I'm like, everybody should get that level of care, right? There's really all of these barriers that we have that are challenging. But to me, if I'm like, I can make a call. So I had a cough for 5 or 6 weeks. Tried different inhalers. My PCP sits right next to me in clinic. Easy, right? Great access, the ultimate access, right? Tried different inhalers, tried antibiotics. I was like, oh, I sound like I'm, maybe a little stridorous. So I was like, geez, maybe it's my vocal cords. Called up my buddy, same day. Hey, come see me at 4:45. I'll fit you in as my last patient. Got an X-ray that day. He looked at my vocal cords, a little boggy, nothing to worry about. X-ray showed a big opacity in my right side. 2 days later, CT scan. 2 days later, bronchoscopy. Monday, pathologic diagnosis, right? It's like a world record diagnosis because I can call people, I got a huge bill. Don't tell him Stanford. There's a huge bill for my CT scan later, which again, because I knew people they could take care of because they didn't submit the insurance stuff in the right time. But everybody really should get that level of care. I saw the oncologist because I know her, chief of oncology. I've been at Stanford for almost 20 years. The next Thursday, got my EGFR, tumor profiling by that Friday. So then by the next week, got my Tagrisso, the osimertinib, which is the targeted therapy for EGFR mutations, by that Friday, something like that, the following week. And then it was lined up for chemo so quickly, right? So that's something kind of my pet peeve is, we have such great care and technology and so forth in the US, but just accessing the system is challenging if you don't speak English, right? If you don't have good insurance, if you don't have resources, if you don't have caregivers, right? If you don't get health literacy, right? This process can take months. There were studies looking about, geez, time from X-ray to diagnosis, time from, first presentation to diagnosis. I mean, it's months. It's months. Yeah.
Amazing. And I know a bunch of people
I
have.
said I was going to keep it short. I didn't keep it short. Sorry.
No, we love it. We love it.
Got me on my soapbox.
Okay, so I know we have a lot of hands raised, but we also have some questions in the chat. So the first one is from Jie, who says that she is diagnosed with lung cancer at 52 years old as a non-smoker, and she's concerned about her kids and wants to know if her kids should start screening in their early 40s.
Oh, it's just a great question. I've told my kids to screen at 40. So, why did I pick 40? I made it up, right? I took my age. I just turned 50 this year. So we're in the same cohort. I took my age and subtracted 10 years, right? So that's, I mean, you know, early signs of, lung nodules grow slowly, is, Dr. Woods, the surgeons can tell you better than me. Um, So yeah, you can catch them early. There was a study I'm sure you guys have talked about in Taiwan in the spring, the talent study, which screened people like me because my family's from Taiwan, and looking at people who have had family history, cooking exposure, ventilation, secondhand smoke exposure, etc. And one of the biggest drivers is family history. So one of our kind of collaborators at Kaiser, at Kaiser, it's great because they can look at large amounts of data all at once, very quickly because they have access. And he has also found that there's also been increasing incidence in men. So as I'm sure the risk in Asian women is higher, double or more than for non-Asian women for non-smoker lung cancer. But that could be because it's kind of masked because the level of smoking exposure among men, Asian men, is higher. So, as that rate of smoking goes down, you may be seeing more cases like myself of non-smoking men. So I would say with a family history, absolutely should get screened. Again, you're going to get me on my soapbox. The USPSTF historically has not. So if something is recommended by the USPSTF, it is covered. Affordable Care Act says insurance has to cover this as a preventative care. You go get your colonoscopy, and it's free if you have insurance because of this. Smoker screening, right? Covered because it's a USPSTF guideline. Historically, the USPSTF has not issued guidelines for smaller populations, right? So what do we do about that? This is something I had a conversation with some of my colleagues about this. What do we do about changing policies so that we can get things like low dose CTs covered for people like me and the person who, for my family, because my fears when my kids hit 40, my kids are teenagers now, it's still not going to be covered, right? So do they have to, pay out of pocket? Do they have to fly to Asia? All of these things. So, I mean, this is a challenge in our screening. Again, don't get me wrong, the fact that screening is covered, awesome, right? But USPSTF is notoriously very conservative. So, what can we do to stay ahead of the curve where, we get this great study, the talent study. Of course, you can argue that's not a US population. God, are we going to have to spend $50 million studying an Asian American US population before we're convinced that low dose CTing is helpful and save lives right now, right? Again, obviously I'm very passionate about this, but it seems not to make any sense, right? We've known through what the work you guys are doing, screening for lung cancer, the risks are low. The risks are low for using low dose, and the amount of radiation being exposed to is decreasing, right, as the protocols improve. So, I would suggest, again, sorry, long answer to that question. I would absolutely recommend, and luckily, you can probably find places that are cheap. A friend of mine, his parents were diagnosed with non-smoker lung cancer. He got a Groupon. He got a Groupon for a CT scan. He was able to get it for $200. I sent one of my own patients over, and actually he was able to get it for $175. So you may have to pay out of pocket, but you can probably find someplace that's reasonably affordable to do it.
Yeah, thank you so much for that. I don't think any of us knew about that Groupon before you, so I think the uses will
I don't know
sky.
if that still exists, but he used a Groupon and he got it for $200. Yeah.
Yes, we'll take a look. We'll take a look.
Before we, Donna, hop on to the next question, there's a question in the chat that piggybacks off that previous question from Laura book, and she asked, how about non-Asian people who have never smoked, who have EGFR lung cancer with no history of lung cancer? Should the children of those people also get chest
In
CTs?
my
How often?
opinion, in my opinion, yes. I think family, I mean, again, do I have the studies and stuff? This is the challenge. Like, when do we start doing things and we have to wait for tons of studies, right? For your family, again, in my view, especially now, every generation of low dose CT, and my colleagues are working on this in radiology, and that the level of radiation exposure has just been decreasing with every development and again, I'll defer to any radiologist who would know better than me, but the risks are low. Yes, there are incidentalomas, incidental findings, but honestly, there's so many CTs done. I deal with those every day as a primary care doctor, and those are manageable, right? Those incidentalomas are manageable, and we have a lot of data around them. So I personally, my personal rate, we don't have guidelines for this, would be yes to do it, to do it, to recommend that, and at least once, right?
Yes, thank you so much for that clarification. And then Alina has our next question.
Hi, Dr. Lynn. Thank you so much for coming and speaking with us today. I just had a quick question because I know most of us, or a lot of us, are college students. So looking back on your career and experiences, what are some things that you would have wanted to tell your college self? Yeah.
Yeah, no, it's great. I assume a lot of you are probably gonna thinking about going to medicine. So, I had a kind of more circuitous path. I studied engineering. I got a master's. I worked for a year in consulting, and then I went to medical school and, did research in medical school, also still started companies and things like that. So, I mean, my thing is, I don't know if I would go back and tell myself this because that's what I was doing. I mean, exploring is really important, right? To me, explore different avenues because that leaves you open to opportunity, right? I mean, whether or not geez, I absolutely want to go into medicine, but exploring different things outside of medicine, even if you want to go into medicine, is really important. Um, so, I would, make sure that, you're not excessively focused on all the check boxes we do to become doctors, right? I mean, the thing about a career in medicine is, there's a very clearly defined path and milestones and things you have to do, right? So it's easy to get sucked down that road. So, it's great. The US system is great in that you can continuously explore. Fantastic, right? You don't have that opportunity necessarily in other countries where you get pushed into a track very early. So my suggestion is just explore, continue to explore, and leave yourself open to opportunity. I think most of the things that happened in my life are mainly because I left myself open to them, not because I was necessarily actively seeking them out.
Thank you for your insights, Dr. Lin. We have a question from Alexandra.
Hi, Dr. Lynn. Thank you so much for coming to speak with us and taking time out of your Saturday. At the beginning, it was mentioned that you teach a course called Storytelling in Medicine. I recently completed a master's in narrative medicine, and so I kind of just wanted to ask a little bit about how you see storytelling playing a role in medicine, your career, maybe lung cancer or not lung cancer related. Anything you have to share about that? Thank you.
Storytelling is important no matter what you do, even outside of medicine. Everything you do is storytelling, right? This is my framework. Whether you're selling cars or technology or yourself, right? It's about storytelling. Specific to medicine, and I mentioned this earlier, and directly relates to narrative medicine, is that, telling your own story is of course helpful. But listening to other stories I found most helpful, right? Hearing what other people are going through. And that's what inspired me to start the class, both to relay to emphasize the balance of what a patient goes through, um, and as well as hoping that when people hear my story, that will be of some help to them. And it seems like it has. So many people have reached out to me with different questions and so forth. So I think it's really crucially important. Of course, there's the whole communication side, right? Just being able to communicate is so important. We're in this interconnected world. And especially in the area of, because I also teach generative AI class, in this era of generative AI, your ability to communicate is even more important because there's so much information out there that may or may not even be generated by a human. So having that ability to tell stories and listen to stories is very important.
Yes, thank you so much for that. I think storytelling is such a powerful tool that's so underused within the medical community, but yeah. We have another question from the chat. So this person is saying that they have EGFR deletion 19 with TP53, and they saw your YouTube saying that you're optimistic that you'll take Tagrisso and current protocol, and you're hopeful getting treatment until the next technology breakthrough. And their doctor is mentioning something fourth generation in Virginia, and they're wondering if you know anything about that.
Yeah, there's a lot of things on tap. Again, it's funny. So in our last two sessions of the class, the second to last session was given by Heather Wakely, who's my oncologist and the chief of oncology at Stanford. And the last session, two of my oncology colleagues, and I'm a primary care doctor, not an oncologist, talking about the future of treatment. And, one, there is no standard treatment for when you develop resistance to osimertinib. There's not, and because the mutations vary, right? You could develop this mutation. So he's absolutely fourth generation tyrosine kinase inhibitors. There are a few kind of in progress. The one of them that's a combination with another drug is lazertinib and amivantamab. God, I can never pronounce that. I'm pronouncing it wrong right now. So that was approved. So that a lot of people are using that currently, either starting with the lazertinib or in the combination, because that had good results. So yeah, it's unclear now what to do when you develop resistance. My comment was, hopefully, and I joked around in the class. I'm like asking for a friend, what do I do? So I asked that same question. I'm like, so what happens when I develop resistance? So we don't really know yet, and there are different things, and maybe even immune-based approaches, cell-based therapy will be more advanced by then. Cell-based therapy like CAR T has been more for hematologic malignancies. But people have been exploring them for solid tumors as well. So there's a lot of hope out there because technology is so rapidly changing. I remember when I was a medical student, God, if you said, oh, somebody with stage 4 lung cancer would be sitting on a Zoom talking to, well, there wasn't Zoom then, but talking to a bunch of people on a Saturday morning and feeling well, having energy, I'd be like, you're crazy, right? That person's going to be very sick, right? And look at me, right? I'm a great beneficiary of technology and I hope to be in the future. I don't know, right? Maybe in 2 or 3 years, tumor gets resistance, or maybe sooner. Could be a month from now. I have my next scans in February. It could be in February that we find my tumors are growing again. But I remain hopeful, and that's again part of this storytelling. When somebody early on, I think it was the pulmonologist, told me, "Hey, you just have to stay alive till the next treatment comes out." And it's true. Like we're seeing, I mean, we see this with breast cancer, right? We're seeing this with metastatic breast cancer, right? The drug companies have come up with a term, right? MBS. Oh, you have MBS, MDC, sorry, metastatic breast cancer. Um, and so it's, sort of becoming like a chronic disease, right? They're turning metastatic disease. So I hope that's the case with lung cancer. Um, but I remain hopeful. Yeah.
Yeah, thank you so much for your insights on such technological and pharmaceutical advancements in this area. We have another question from Sunny.
I see some of the direct messages to me about people's experiences, and it's great. I love to hear from people who are surviving. So it gives me hope, right, to hear these stories where people are surviving for years and years and years. Yeah, which is great. So I'm hopeful because my youngest son is 13. So I'm like, God, I want to make it till he graduates from high school, right? So I love these stories. It gives me hope. Sorry, yeah, I know people are sending me direct messages. It's hard to do it simultaneously. So yeah.
What we can do, Dr. Lin, is we can try to download the chat at the end of the meeting and then send you an email with all of the
Well, I
chat.
don't know if you're getting the direct messages, so Yeah.
That's true. Yeah. If anyone has questions, I'll also put our email in the chat. And if you have questions for Dr. Lin that we don't get to, you feel free to send them over email as well, and we'll get those to Dr. Lin. But I'll hand it back to Jessica.
Yeah, so Nish, would you like to ask your question?
Yeah, thank you, Dr. Lin, for all the things you've said. You're such a great inspiration for all of us. Just one quick question. Given your experience in generative AI from Med 216, I was wondering if you have any specific research in AI for lung cancer, and if you see opportunities for Gen AI to play a significant role in particularly lung cancer care.
Yeah, so there's two parts, right? One is kind of the clinical care, right? Using and a lot of Gen AI is basically around making our current system more efficient and just better, right? It's like making the machine work better. And with cancer care, that actually makes a huge difference. I don't know if you're familiar with, I'm sure the physicians are, 2017-18, there was a study presented at ASCO, the Clinical Oncology Society, about patients using at the time, sounds kind of antiquated now, but basically a patient reported outcomes. Patients were reporting their symptoms on a somewhat clunky system, honestly. And the survival benefit was 4 months. 4 months, like incredible, right? It's been harder to kind of translate that to practice. There are a lot of systems out there, but it just goes to show you on that clinical care side, if we make things, improve the quality and the speed and the flow of communications, that can help patients right away, right? Potentially 4 months. I mean, that's on the level of like an FDA approved drug. If you had a drug where you said, hey, where you proved in a clinical trial that people had a 4 month survival benefit, oh my goodness, right? That would be approved, right? Assuming there were, no side effects, no concerning side effects that were unexpected. So that's one side. On the drug discovery side, lots of people using generative AI. We don't know how that's going to shake out, right? Is it just increasing the number of candidates we're putting in the pipe, right? So there's kind of screening, there's they're actually finding, specific candidates, but also screening them against targets. So a ton of work being done everywhere on this area. So hopefully it'll help. But you still need funding, right? You still need to do because we haven't changed our clinical trial framework because we haven't found a better way yet. So you still need to spend the time and money, but it may accelerate that drug discovery process, that very first part, but it doesn't allow you to skip steps of the safety, preclinical trials, phase one, phase two, phase three. Those are still going to have to be done. So I think there's a lot of hope, but it's not a magic tool. I think that the lowest hanging fruit is really the clinical care component.
Thank you so much for your perspective on AI, Dr. Lin. And we actually have a comment from Dusty from Live Long, and she said, "Thank you for being a beacon of hope." And then Pierre and Heidi also emphasized that. So yes, thank you so much for that. And then we have a question from Isha in the chat, and we'll be alternating between chat and raised hands, just so everyone knows. Isha says, "Thank you, Dr. Lin, for sharing your journey and insights. My question to you is, from your experience as both a primary care physician and now as a patient with lung cancer, what gaps do you feel exist in primary care when it comes to advocating for and implementing lung cancer screening? How can primary care providers better identify and address these barriers, whether related to patient awareness, systemic issues, or access to ensure early detection becomes more widespread?"
Yeah, it was a great question. So, yeah, as you guys know better than me, for smokers, the lung cancer screening rates are still fairly low, considering it's been, several years since this has been, covered and, in the USPSTF guidelines. Uh, so I would say, first, implementing systems. So that's what we've done at Stanford, where we're flagging people and saying, hey, this person, you need to remember this person is due for their screening, right? So we have actually multiple levels, both on the electronic sense, but we also have actually a whole kind of team working on this where they will flag and identify people. The other part is, gathering the information, right? Where we we're not, getting enough information to see so that way the system knows they should be screened, right? And the challenges in primary care, I think there was a study that said if primary care doctors did all of the required screening and health maintenance, it would be like 25 hours a day. Literally is like crazy, right? So this is the challenge is that, we already have access problems getting in to see doctors. So, that we need to maybe come out with a new system for, screening, right? How do we do that? Because you don't necessarily need a physician, right, directly involved. Like we're doing this much better with mammograms. I don't know if it's a California thing or nationwide. Patients can self-refer for mammograms now. You don't need to go and self-refer, which is great. And then they have a protocol to do this at Stanford. So I don't know if we set this up Stanford. I don't know that I'm not as familiar with, breast cancer screening and what the rules are. But it's great, right? Patients don't have to have an order. They can just go and they can call and make an appointment. So, should we have something like that for lung cancer screening, right? Should we have something? So I think, yeah, all of the issues are concerning and can be improved. The other part, again, I'm going to harp back on is, the USPSTF is slow to adopt new things. So right now, right, you have to quit with it. You have to be either current smoker or quit within the last 15 years to qualify, right? American Cancer Society changed that and said on their guidelines, oh, doesn't matter when you quit, right? So I had all these patients messaging me. They knew about this before I did, right? The day it came out. And, but still, USPSTF hasn't changed their guidelines, right? So, I'll order one for a patient. They'll be like, well, it's not covered. They quit 16 years ago, right? Not covered, right? So there are multiple challenges for any screening test. So yeah, thank you for all the work you guys are doing to improve our screening rates.
Yeah, thank you so much for highlighting those unique challenges in preventative care, especially within the PCP setting in terms of the guidelines. And our next question is from Jacob.
Hi, Dr. Lin. Thank you for all your amazing insight thus far. So, we know that often there's a stigma associated with lung cancer and lung cancer patients, especially in regards to smoking. So, I was wondering, as a non-smoker, is this stigma something that you've encountered since your diagnosis or even in your experiences as a provider?
Absolutely. I would say generally having a cancer diagnosis, there is a stigma. So people, I think because of the stigma, a lot of people don't want to share. So there's a lot of reasons people don't want to share, and it's they're keeping private, which is great. But part of my motivation for starting a class is I wanted to reduce that stigma of sharing your cancer experience if you want to because people are worried about how other people view them, right? So I think there's stigma on both sides, stigma on the smoking side. Hey, somehow this was a moral failure, right? Because you're smoking, right? We know, so that's a bias and not appropriate, but people worry about that, right? But also I think from the non-smoking side, I think people worry about sharing it because then people assume they're a smoker, right? People assume, so there's that other side of that as well. So I think generally for cancer diagnoses, there is a stigma to share your what you're going through, and hopefully that stigma will reduce over time. So I'm trying to play my role by sharing my story widely, so people don't. I feel if they feel it's appropriate for them, would be maybe more open to sharing their own experience.
Yes, thank you so much for talking about the stigmas associated with lung cancer and being so open with your own story. We're definitely beneficiaries of that. And I'm sure a lot of people can speak to the fact that they really appreciate it. And our next question is from Anisha in the chat. So Anisha's saying, one question that I have is, what do you think are the best avenues to get insurance companies to cover lung cancer screenings for non-smokers and to help drive funds toward lung cancer research? My understanding is that lung cancer research is very underfunded. My mom was diagnosed with stage 4 cancer, and we do not work in the medical field. So I was wondering if you may have some insights.
Yeah, so definitely lung cancer research is underfunded relative to other cancers. Underfunded, what does that mean? But definitely relative to other cancers and given the prevalence, right? It's the number one cause of death from cancer in the United States and the world. And sorry, what was the first part of the question?
So it was just asking what the best avenues to get insurance companies to cover
Oh,
lung cancer screening for non-smokers.
yeah, so that's challenging because everybody relies on the USPSTF because that's required by law. I was talking with my colleague recently, and we were talking about, well, maybe it should be like drug coverage where, basically you go to each insurance company and, you try to convince them. But that's the way the system was before. So that's also very onerous. So yeah, I think to me, the best way is to perhaps have more organizations where if their recommendation, their guidelines, like the American Cancer Society, rather than waiting for the USPSTF, American Cancer Society, if their guidelines recommend screening, then, hey, this is on, not, you don't have to wait for the USPSTF. If American Cancer Society says, hey, this is something we should screen for, then that should be covered, by insurance. So I think there's avenues with policy. I think it would be difficult because that's the way the system was before, insurance company by insurance company basis.
Thank you for your insights on this. Our next question is from Jill.
Hi,
Oh, perfect. Yes, I was gonna go ahead, Joe.
can you hear me?
Yes, we can hear you perfectly.
Oh, okay. I recently received the same diagnosis in October, and I was just wondering what, besides Tagrisso, you're doing for your diagnosis, Dr. Lin?
Sure. Yeah, sure. So Flower 2 study, which was published late last year, showed that for people with advanced lung cancer and I'm stage 4B, would benefit, had a progression-free survival benefit of being on chemotherapy plus Tagrisso. So, especially because I had great performance status, relatively young, I was a good candidate. So I was placed on carboplatin and pemetrexed. So I received 4 cycles of that, and I'm still getting every 3 weeks pemetrexed as a maintenance. Now we're probably going to stretch out to every 4 weeks. But that showed the group that did chemotherapy plus Tagrisso had a progression-free survival benefit over the people who were on just Tagrisso alone in this group of patients who were with advanced EGFR mutated lung cancer. So that again, evidence, just an example of how evidence changes so rapidly. If I'd been diagnosed a year ago, I probably would have just been placed on Tagrisso alone.
So I'm at MSK, and they're just giving me Tagrisso. I'm wondering if I should ask for the
Well,
chemo.
yeah, so there's a lot of details. I don't want to comment on specific, um, you know, specific, cases. It could be because of the burden of your disease is low. It could be because, maybe they had concern for side effects. I had a very high burden of disease. Um, so I had 50 Mets to the brain, 50. I had never seen that physician. Like it's always like, oh, there's like 3 or 4, I had 50 areas. So
Wow.
poor radiologists who counted like all the different spots in my brain. I had Mets to the, of course, large, several, I had 2 or maybe 3 because it was just everything was opaque. It was hard to differentiate areas in my lung. I had a huge pleural effusion, of course, mediastinal lymph nodes outside. Actually, I had bumps of cancer in my skin. I could feel on my scalp. Spread to the bone, to the liver, probably the adrenal glands. And it's amazing. All of those shrunk. I could feel them shrink on my scalp. It was incredible. And all the 50 Mets to the brain have now gone, which is amazing.
Wow.
So I had a high burden of disease. So just to caution, definitely you should ask about it. Again, every case is different. I would ask. You should always ask. But in the past, the practice was to put people on Tagrisso, and then if they developed resistance, then to do chemotherapy. So, again, I would ask about that and see. There are again a lot of details depending on stage and so forth, and burden of disease, and also performance status, like how they think you could tolerate the chemotherapy. Because it's no fun. I wouldn't wish chemotherapy on anyone.
Yeah.
It's no fun. So
Can
yeah, so definitely ask. Yeah.
can I just ask if you've heard anything about surgery at stage 4? Because I was told that they don't do it, but I've heard that MD Anderson is doing it.
Yeah, so a lot of details here. So yes, generally no. Sometimes in cases where God, your cancer is really, really shrunk and maybe there's only something left and you're a surgical candidate, sometimes they'll do it. It's not clear if, again, this is the challenge in medicine generally. We treat people based on populations of data, right? It's really hard to translate populations of data to individual cases. So yeah, so sometimes if you have oligometastatic disease, they will do something called consolidative therapy, more usually focused around radiation and things like that. Um, Evidence is unclear. There was a study last year which showed that doing these spot treatments and things not clearly beneficial. Um, so yeah, a lot of the devil's in the detail, but I mean the overall principle, and it is, I know exactly where you're coming from, Jill. You think, I've got this in my lung, why don't they take it out, right?
Yeah.
Right? That's what, but keep in mind, because you have stage 4, you have metastatic disease. It's many places in your body. So the question is, will taking that primary out help you? And we, for stage 4, we don't have clear evidence that's the case,
Mhm.
right? And of course, there's risk of surgery, there's pain, all these issues. So it's a really great question, but I do personally feel, yes, that's always there. It's this in the back of your mind. It's like, oh, geez, if they just went through and took out the lung and then they did radiation to these other spots, right? Maybe it'll all be gone. And we don't have clear evidence that's the case. Although there is some thought about for people with EGFR that because the resistance can happen in certain areas, maybe you should spot treat those areas, right?
Mhm.
So yeah, it's a great question, but I think the standard of care to me is appropriate. But yeah, I'm with you. It's that in the back of your mind is like, well, now, like for example, I've got lung spots and bone and liver, so I'm like, well, maybe the bone spots are treated because it's sclerosed and it's really hard to tell. And then, geez, they could do radiation to the liver and then take out my lung, right?
Mhm.
But, if you do that and pain and suffering, et cetera, and it doesn't help, that's challenging, right?
Yeah.
So yeah, it's a great question. It's tough. We don't have clear evidence that that will improve your mortality, right? But it may increase your pain and suffering, right?
Mhm.
So it's very tricky. It's very tricky. So I totally hear you. I know where you're coming from. I have the same thoughts in my head, but yeah, the evidence to me is not there. Yeah.
Thank you.
Thank
Yeah,
you,
th
Charles.
thank you, Jill, for that question, and also Dr. Lin for that really insightful answer. I'm going to speak a little out of turn real quick because I know we have some amazing thoracic surgeons here on the call. I don't know if Dr. Wood, Dr. Cook, or Dr. Kashava want to give some thoughts on from the thoracic surgery perspective on that question.
Or the amazing thoracic surgeon, Dr. Jeff Yang, could do that also. But yeah, I think there were a couple of comments, and so just to and reinforce what was said nicely in the comments, um, oligometastatic disease that Dr. Cook mentioned, where there's a very limited metastatic disease might be appropriate for surgery in selected cases. The other situation is what appears to be very successful treatment where you do not see evidence of distant disease any longer, yet the lung primary still appears to be active. That's another case that we are sometimes doing surgery for stage 4. So predominantly in those two situations, it has selective utility. And as Dr. Lin said, a population decision of we're not going to do it ever for stage 4 is incorrect. I think we actually have increasing indications of being able to do surgery in these very specific circumstances.
Yeah, This is David Cook. As usual, I cannot add on anything that Dr. Wood has said. But what I want to do is take this opportunity to really thank you, Dr. Lin, for your amazing, candid insights and perspectives, especially as your perspective as a healthcare provider and an oncologist who really knows this space, and then now is a patient. I've been finding your patient journey as being fascinating, and really illustrative of what we can do to better improve our care processes and the care pathway for our patients. So timeliness of getting into our cancer centers, timeliness of biopsy and diagnosis, timeliness of genetic profiling of the tumor, identification of treatment protocols, and then screening for clinical trials, getting imaging on time and quickly, getting a multidisciplinary tumor board discussion quickly. As we've learned from COVID-19, cancer is not elective, it's urgent, and it doesn't wait for anything. It doesn't wait for pandemics or labor strikes or anything. So I really appreciate your insight, and I always find someone who is really an expert on the inside and their perspectives to be helpful to improve our clinical care processes.
Well, thank you for the kind words, and I'm glad it sounds like I didn't say anything wrong about the surgery for stage 4, so that's good.
All right. Thank you so much to all of the amazing thoracic surgeons for their commentary, and also Dr. Lin for your response. And okay, we are running short on time. So I think we'll give the last question to Pankti. I know Kiana and the amazing chat questions are also there, but we'll collect them, and then we'll get them to where they need to go. So Pankti, go ahead.
Yeah, thank you so much for being here. I guess just a question I was having is like something that strikes out to me, is that you didn't have a direct path to medical school. I remember you mentioning like the importance of exploring and especially from your own experiences, consulting. I was curious to know how you decided that the medical field was the correct path for you. You also mentioned generative AI and like these technological breakthroughs, and I was also wondering like what sort of, I guess, quote unquote, like benefit a physician might have who is maybe like more comfortable with like coding or technology or all of those things.
So yeah, I think, to me, it just harks back to what I said earlier about exploring. To me, it's, the great thing about the US system of education is we can explore and we have that opportunity to try different things. To me, it was really about medicine's this great place where you can do many things, right? You can do research, engineering, education. You can do, humanities and arts, right? So it's a great place to be if you like many different things. I think with the generative AI side, I think whether or not you code, this is just the reality of our life for the next, for the for the foreseeable future, is that there are all these technological advancements. So you got to be familiar with them, whether you code or not. So I have my 13-year-old son. He sits there. Anytime he asks me a question, I'm like, about coding or anything, I'm like, try ChatGPT. You need to get experience using these tools. And so I recommend all my students just to use them and to understand their limits and the benefits. So whether you code or not, and actually, even if you don't code, ChatGPT can teach you to code. So, I really encourage people to explore, and it's hard to stay up to date. I mean, you look at this like oncology, right? Things changing so quickly. Now it's really hard to be a general oncologist, right? Because it's like you really have to subspecialize in a specific area, because it's just, hard to keep up broadly outside of, for all of the advances. And that's the case in medicine altogether. It's just things change rapidly. So, yeah.
Well, thank you so, so much, Dr. Lin. This concludes our distinguished lecture. I also want to thank the 125 plus people who joined us. It was truly an amazing discussion with all of you. And Dr. Lin, thank you for taking the time to speak with us. We are just so grateful to have the opportunity to learn from you, and we're just so deeply inspired by your selflessness and devotion to improving healthcare and teaching the next generation of healthcare providers on this call. It's truly incredible to see the tremendous depth and variety of all the work you've done. It's been amazing to listen to you on your soapbox. I think I speak for all of us when I say that. And so before we close, I would just love to get a group photo of everyone. And so if you're comfortable, if you could turn your camera on, and I'll just take screenshots as I scroll through the 5 pages. So I'll just begin now. So 1, 2, 3. And I'll tell everyone when to stop smiling. Just almost there. Okay, perfect. Thank you all so much again. And Dr. Lin, this was truly very special. Thank you.
Thanks for having me. Really appreciate it.
Thank you so
Thank
much.
you.
This is amazing.